Welcome to my channel. In this video, we will talk about asthma. What's an asthma? It's a chronic inflammatory condition characterized by narrowing of respiratory passageways causing shortness of breath. What's the etiology? We don't exactly know the underlying etiology, but there may be some genetic predisposition. There is a specific triad called atopic triad. There are three conditions in this triad: asthma, eczema or atopic dermatitis, allergic rhinitis. These three conditions are due to genetic predisposition. People with this genetic predisposition might have a family history or some underlying genes that make them more predisposed to respond in such a way that particular allergens cause them to produce massive amounts of inflammatory mediators, which produce this bronchospasm of the respiratory passageways. It can be related to another triad called Santer's triad. Again, there are three conditions in this triad: asthma, nasal polyp, and aspirin sensitivity. For some reasons, in some individuals, when they take aspirin, they might develop some type of sensitivity against aspirin, and it can shift the balance of arachidonic acid pathway, inhibiting the COX-1 and COX-2 enzymes, which aren't able to make prostaglandins, and thus shifts this pathway into making leukotrienes like leukotriene B4, C4, D4, and E4, which produce intense bronchospasm. Some of the triggers which aggravate asthma are the environmental factors like dust mites, pet hair, bugs like cockroaches, cold or exercise, respiratory, usually the viral infections, usually the upper respiratory tract infection triggers the exacerbation of asthma, smoking, and beta blockers. There are beta-2 receptors on smooth muscles of bronchioles. If someone is on beta blocker, the epinephrine or norepinephrine, which normally binds with the beta-2 receptors and promote vasodilatation, are going to be blocked, and it leads to bronchoconstriction. Coming to the pathogenesis. A particular type of allergen, when it comes into contact with the antigen-presenting cell here, like a dendritic cell, it will phagocytose the allergen. When it phagocytoses it, it also activates particular genes, like chromosome number 6. There's the MHC2 complex, which gets activated and expresses the allergen to this complex and brings it to the T helper 2 cells. The T helper 2 cells, which has a C2,4 molecule on its membrane. Now this T helper 2 cell react with the dendritic cell and interact with the MHC2 complex, which has that particular allergen. So binding of this MHC complex with T helper cell causes inappropriate type of reaction and produces two chemicals, the interleukin-4 and interleukin-5. Interleukin-4 activates the plasma cells to produce specific antibodies like the IgE antibodies, which bind the mast cells. The mast cells have a particular protein on their membrane called Fc epsilon R1 receptor, which bind with the IgE antibodies and triggers the degranulation process and produce massive amounts of histamine and lot of leukotrienes, which are the inflammatory mediators. Now this interleukin-5 activates a particular WBC, like the eosinophil, which releases leukotrienes and also releases cytokines, which are going to attract other blood cells, particularly more eosinophils. It also releases proteases, which cause the tissue damage. So these histamines leukotrienes and proteases. They're going to affect the mucosal area of bronchioles and causes constriction, that is the bronchoconstriction, thus narrowing the airways. Histamine also causes increased capillary permeability, causing inflammation and mucus production, and due to this the mucosa of the bronchiole is now filled with these inflammatory cells, making it inflamed mucosa. Now all these occur in acute phase response. In chronic cases, over time it can become fibrotic and permanently narrows the passageways. Now the signs and symptoms of asthma. There is cough, sometimes it's productive, tightness of chest and shortness of breath, and person has difficulty in breathing. Now the diagnosis. We do the physical examination, and physical examination we do the inspection. The person will have difficulty in speaking due to the hard time breathing, and he will use his accessory muscles. On percussion, there is the high pitch sound. This means there is hyperresonance. In auscultation, there will be wheezy chest. Now, the histology of sputum will show Kirschmann spirals. They are spiral-shaped epithelial cells with mucus plug. The other thing we will see is the Charcot-Leyden crystals, which are breakdown pigments or products of eosinophils. If the patient is symptomatic, we will do pulmonary function tests. It's the gold standard test. And if someone has asthma, his FVC, that's the forced vital capacity, will be decreased. Forced expiratory volume V1 at 1 second will be significantly lower, and his FEV1 FVC ratio will be less than 75%. It means it can lead to some obstructive condition. If we give a bronchodilator to such patient, like the SABA, this short-acting beta-2 agonist, to such patient, and then repeat the test, repeat PFTs, we will notice that FEV1 will significantly improve to 12%. If it improves to 12% or more than 12%, it's definitely asthma. If FEV1 is less than 12% after giving SABA, it means it's not asthma. It may be COPD like chronic bronchitis and emphysema. Now there is another test called methacholine challenge test. If a patient is asymptomatic, then we will do the PFTs, and here the FEV1 will be low, FVC will be low, and FEV1 FVC ratio is less than 75%. We give methacholine to such patient. This methacholine binds to the muscarinic receptors of respiratory passageways and causes bronchoconstriction. If a patient has asthma, he already has bronchospasm, so it will cause even more spasm. So we repeat the PFTs. If FEV1 drops 20% or more from original, it indicates it's definitely asthma. Now the CBC picture will show increased WBCs, that is more eosinophils particularly, increased IgE. We also do chest X-ray to rule out other respiratory diseases. If it is asthma, there will be hyperinflation of lungs. Now the treatment. Treatment is given based on type, frequency of symptoms during the day, frequency of symptoms during night, FEV1 between exacerbation, and will give treatment accordingly. If this type is of intermittent type, means his frequency of symptoms would be less than 2 per week. Usually he has less than 3 episodes per month, and his FEV1 between exacerbation is more than 80%, then we will give SABA, that is short-acting beta-2 agonist. If the type is of mild type, that's in the mild stage, then he will have more than 2 episodes per week during the day, 3 to 4 episodes per month during night, and his FEV1 will be equal to or more than 80%. So we will give SABA plus inhaled corticosteroid but in low dose. If it is the moderate stage, there will be at least 7 episodes per week during the day, at least 1 episode or more per week during night, and this FEV1 will be between 60 to 80%. So we will give SABA plus inhaled corticosteroid in medium dose. And the second option will be we give low dose inhaled corticosteroid plus LABA, which is the long acting beta-2 agonist. If this is severe stage, means the symptoms are throughout the day, every night, throughout night, and FEV1 is less than 60%. So we will give number 1 SABA plus medium dose inhaled corticosteroid plus LABA. The second option will be SABA plus high dose inhaled corticosteroid plus LABA. The third option will be SABA plus high dose inhaled corticosteroid plus LABA, and we also gave oral corticosteroids. These oral corticosteroids may be methylprednisolone, prednisone or prednisolone. We give them for short term because they have a lot of side effects. Now, if a patient comes with acute asthmatic exacerbation, then we cannot perform PFTs in such patients because of so many reasons. We can do PEFR, that is the peak expiratory flow rate. This PEFR must be more than 70% of age, gender and height. Now there are different scenarios. If a patient comes with acute exacerbation, we give him SABA, and if he improves, we discharge him. Another scenario, if a patient comes with acute exacerbation, we give SABA, but he doesn't readily improve, we do the PEFR. If this PEFR is less than 70%, like between 50 to 70%, definitely it's not good. We might do ABGs in patients with some underlying chronic lung disease, and there will be decreased PCO2 because of the hyperventilation. Now, there's another scenario. If a patient comes with acute asthmatic exacerbation and his respiratory rate is more than 20 to 25 per minute, heart rate is more than 100 to 110 per minute, and his PEFR is between 25 to 50%, then it's very bad. It means he has severe asthma. Definitely we do ABGs, and there will be decreased PCO2 because of the hyperventilation. Now if patient comes with acute exacerbation, this is the fourth scenario. We do their oxygen saturation, that is the pulse oximetry. If it is less than 92%, it's very bad. We do the PEFR. If it's less than 25%, there will be no wheezing and there will be no hyperventilation. The ABGs will show normal PCO2 because there will be, at this point, the airways are already so obstructed that the carbon dioxide is not even being exhaled. Now the question is, why is this normal PCO2? But before the PCO2 is low, the airways become so obstructed that PCO2 starts to build up and it goes from low to normal PCO2. This is a very bad sign. Probably it can lead to near fatal exacerbation. So there will be normal PCO2, no expiratory wheezing, and the PEFR is less than 25%. The oxygen saturation will be less than 92%. Means that probably he is having complete airway obstruction. Now, if the patient comes with acute asthmatic exacerbation, this is the fifth scenario, and he has super low oxygen saturation, that is less than 92%, and his PEFR is less than 25%, with no wheezing and can't even talk, is not even able to talk, we will do ABGs, and there will be elevated PCO2. It means he has complete obstruction. It means he has respiratory acidosis. Again, it's a very bad sign. It's a very bad situation. He needs immediate treatment. Sometimes we even do the treatment without doing ABGs and chest X-ray. We need to treat such patients immediately. Now, what are the treatment options? We first do the non-rebreather supplemental oxygen with a saturation of more than 92%. It helps to push a lot of oxygen in them as compared to the nasal cannula. Secondly, we give SABA, that's a short-acting drug, short-acting beta-2 agonist, but best is to give them ipratropium bromide. We usually give these things together, and we give in two ways, in nebulized form or through inhaler. This ipratropium bromide is an anticholinergic. It binds onto the muscarinic receptors and prevents the acetylcholine from binding to muscarinic receptors of the respiratory smooth muscles, and blocks the action of the acetylcholine and allows the smooth muscles to relax. It's a short-acting muscarinic antagonist. We also give, if this doesn't work, we give per oral or IV steroids to reverse the inflammation. If that doesn't work, we give IV magnesium sulfate. This we give in very severe situations. Magnesium sulfate blocks the calcium channels in smooth muscles of the respiratory system, causing dilatation. If that doesn't work, we shift the patient to ICU and give him positive pressure ventilation. If that doesn't work, we might intubate the patient through endotracheal tube, and eventually whenever we discharge the patient, we usually send them home with an oral corticosteroid for a couple of days. So that's all for today. Thank you for watching.